Connected by purpose, driven by passion. This is Children's Healthcare Canada's Spark Live webinar series.
Children's Healthcare Canada would like to thank our Keystone funding partners for their ongoing contributions that support all of our programs and activities, including this Spark Live weekly webinar series. Spark Live is where we gather each week to curate, convene, and showcase excellence and innovation from across the child and youth healthcare community. Our goal is to spark conversation, ideas, and action. There are two options to join in on the live conversation. Questions and comments for our panel or presenters can be typed into the question box, or comments that you want to share with the audience can be typed into the chat box and be visible to all of the attendees. For those of you on Twitter, tag @ChildHealthCan on any webinar-related tweets or use the hashtag SparkLive. And to keep up to date on all of Children's Healthcare Canada's webinars and other activities, be sure to sign up for our weekly Spark Bulletin by visiting our website at childhealthcan.ca.
Hello everyone, and welcome to another edition of Children's Healthcare Canada's Spark Live webinar series. I'm Paula Robeson, your host for the next hour. Children's Healthcare Canada acknowledges that our offices located in Ottawa are on the unceded, unsurrendered territory of the Algonquin Anishinaabe people. We're grateful to have the opportunity to be present in this territory. Today, we're delighted to welcome Children's Healthcare Canada member Saint-Justin and our sponsor for this session, Mallinckrodt Pharmaceuticals, for Health Outcomes After Premature Birth, What Matters to Parents and Families. As mentioned in the intro video, please type your questions into the question box at any time. I'll prompt you via the chat as well, and I'll pose the questions to our speaker at the end of the session. I'd like to introduce our speaker today. Dr. Annie Janiver is a neonatologist, a clinical ethicist, and an author working at the University of Montreal and Saint-Justin Hospital. She works first with patients and families confronted with difficult decisions such as end-of-life issues and decision-making in the face of uncertainty. And it's my pleasure to pass the mic to Dr. Janiver.
Thank you. It's a pleasure to be here today and speak about health outcomes after premature birth and what matters to parents and family. So as a disclosure, I have no association with Mallinckrodt. I'm also the mother of 3 children, one of which was born at 24 weeks. So I've been a patient advocate for a while, either as a neonatologist, as a researcher, or as a parent. So for those who are participating and don't know about prematurity, usually we have a pregnancy that lasts 40 weeks, and prematurity means being born before 37 weeks. So about 8% of babies in Canada, 12% in the US are born before 37 weeks. And you see that about 10%. And being born extremely preterm means being born before 28 weeks. So it's about 1% of babies. But because there's many babies being born, there's still a significant amount of babies born preterm in Canada. And survival rate is quite high and has improved in the last decades. So if you look at survival at 23 to 24 weeks, it's about 62%. It's even higher in the later years. It's 25 to 26 weeks, it's about 90%, and it's 95% and above at 27 and 28 weeks. And if you want all the data on preterm births, you can go on the Canadian Neonatal Network. You'll have all that data. It's online for everybody. Although there's more survivors and neurodevelopmental impairment has gone down, there's still a lot of babies that have disabilities, because during the 3rd trimester, there's a lot of things growing and organs growing in when mom is pregnant. And for sure, when organs are growing outside of the mother in the NICU, there's more problems. There's more lung injury, brain injury, oxygen toxicity, mechanical ventilation takes place. So we have to follow up how these babies do in order to improve not only survival, but long-term outcomes. How do we do that? Neonatology is one of the only places in the world where there's systematic follow-up of all the patients that may have long-term disabilities, especially those that are more at risk. So neonatal follow-up is a discipline within pediatrics that monitors how preterm infants grow and develop. So here on the mosaic, you see the most fragile babies that were born before 26 weeks of gestational age. So how does this work? In neonatology, all the babies that are born in hospitals where there's NICUs are actually entered in a database. They're of course anonymous, the Canadian Neonatal Network. And the CN Fund is a Canadian neonatal follow-up network where outcomes are entered in a database so we can actually follow up how babies are doing throughout Canada. So all babies that are followed up are those who are born less than 28 weeks. A lot of babies who have reasons for us to follow them are also followed up. For a 35-weeker with asphyxia will be followed up also. And how are they followed up? There's a standardized assessment between 18 and 21 months. And then it happens at 3 years, 5 years, and in some centers, 7 years. And we examine hearing, vision. There's a physical exam where we can screen for cerebral palsy. And there's the Bailey assessment, which is a screening assessment that examines language, cognition, and motor skills. So all these are entered in the CN Fund database. So today I'll speak to you about a parent's story who of course agrees to share her story. She's also published about her story if you want to find it. Why question ourselves, why are neonatal outcomes measured? Speak a bit about our Parents' Voice project and about how we can better do research with families and not about families. So why have we chosen the way we measure neurodevelopmental impairment? In fact, when I told you what we are measuring at 18 months, which is any problems in hearing and seeing, screening for cerebral palsy, and then movement and a screening Bailey outcome, we have to ask ourselves, why are we measuring this? And who decided that? In fact, it's doctors and researchers that have decided to follow this. They've not asked ever parents, what do you think we should follow in your child? Or what bothers you the most? Or what is the most disabling for your child? We decided years back to measure these outcomes. And we've never really questioned parents whether these outcomes were important or the most important. So the story of Marin, Marin was a twin, is a twin, and Lily was her twin sister who died. She was born at 25 weeks in 2009. Lily died of an infection that Marin then had that got treated. She had a very unstable course in the NICU with sepsis, with candidemia, with a PDA ligation, with steroids to get her extubated, with steroids for respiratory failure. And she was on the ventilator, including the sensor medics for 7 weeks, for those who know the Poutine and the NICU. She survived with severe BPD, and she went at home on oxygen. And the week before the discharge, an MRI was done. At that point, we didn't do systematic MRIs for all patients, but it was almost depending on who the neonatologist was on. And some neonatologists just ordered it without speaking to parents, which is what they just said, we'll do an MRI to see if everything's okay. And Marin's MRI was abnormal. Now, what do we know about MRIs? We know that when the MRI is normal, 90% of children are devoid of disability as described by doctors. And when the MRI is abnormal, 50% of kids are devoid of disability as described by us. Of course, that MRI totally shattered the couple. That wrote a great paper, if you want to read it, Term MRI for Small Preterm Babies. Do parents really want to know, and why has nobody asked them? Who said this was devastating news and it really harmed them because there's nothing you can do about the results. And it just went to get them very stressed. They were imagining the worst outcomes. And these parents are both, one is a teacher and one is a researcher in immunology who has a PhD. And they looked at outcomes of preterm, and they actually asked questions of, why is it disabled or not? Why isn't it a continuous outcome? They were asking good questions like, what is the quality of life and what is the functioning? They say, cerebral palsy is not helpful if I don't know how my kid functions, like how they integrate, if they're happy. Why are we doing all these screenings? They're very stressful and there's nothing much we seem to be able to do about it. And what are real life outcomes? Like, what is important to families and how do families cope if children have difficulties? And why is so much of the research on preterm outcome deficit based? We measure kids, they're not fine, but there's a lot of money placed, for example, in MRIs in preterm infants, but not much money with what do we do about this and how do we help families? So, we teamed up with them and started researching, and this is another great paper that they have written with us of how to communicate meaningful outcomes. So today, Marin is a 9-year-old. She has some problems in school. Everything was not perfect. She had a lot of readmissions, but the family is very happy. And what many parents say, and if we look at the research of Soroush Segal, is that outcome measures reflect our values, the values of researchers and doctors. And when you ask parents, this is a summary of many articles, but this is Becky's slide. It's devastating, but does it have an impact on most families on a daily basis? Generally, no. Are most preterm children happy? Yes. Are most independent and functional? Yes. Do most have friends? Yes. Do most do okay in school? Yes. Do most have serious long-term health problems? No. Are they strong and resilient? Yes. And are they funny and kind? Yes. And mostly, do the parents of preterm children love and value them? Yes. And then I said, Becky, it's nice that you have your slide, but maybe we should ask parents questions about that, about what all these things mean and what prematurity means to them, as opposed to just say a yes and no, even if it's based on valid research. So why do we measure outcomes? I think there's good reasons to measure them, to screen and assess, clinically to say, oh, your child is starting to develop signs of cerebral palsy. Let's see a physiotherapist to help, at least that your child can reach his optimal development. It's also important for quality improvement. So each year when we submit all our data on how our babies are doing on survival, on outcomes, sometimes we had a lot more infections or we had a lot more cerebral palsy this year, or a lot less eye problems. And we can then see, is there anything that changed in ICU? Should we improve something? And improvement within Canada happens in neonatology. And it's a very strong field that we have to be proud about. Another way we use research, clinical outcomes at 18 months and so on, is for research. So you do a randomized trial, you need to measure something. And what is most measures is NDI, neural developmental impairment, as described by neonatologists and researchers. And the fourth reason is to inform and help parents. And also to inform them in the delivery room to make life and death decisions. using these statistics. So there's problems with outcome measures that we've already mentioned. It's clinicians and researchers that decide the categories of neurodevelopmental impairment. So severe were described as cerebral palsy, deafness, blindness, developmental delay, less than a certain percentile. It depends on the research you read. Mild is described as hyperactivity, for example, or learning difficulties. But when you speak to parents, a lot of parents, and you'll see with our data of children with cerebral palsy, a child who limps, for example, a little bit, say that their disability is mild or that they have no disability. On the other hand, children of parents who have extreme hyperactivity and can't function all day, neither at school or home, say they have a severe disability. So it's really the categories that we have decided as researcher were severe, moderate, and mild may not fit what parents think. The other problem is we often conflate outcomes. So when we do randomized trial, we, for example, test levels of oxygen or ways to ventilate babies, and then the outcome measure is conflated: death or NDI, death or BPD, death or retinopathy. And we don't follow the guidelines for conflating outcomes. In order to conflate these outcomes, they need to be of similar importance to patients. They should have a similar relative risk, and their frequency should also be in the same range. So for example, death or lung disease for a parent, it's not the same thing if a kid is dead or if he has lung disease. And we don't see that anywhere else in the literature. For example, in the colon cancer literature, we don't see death or colostomy. In the prostate cancer literature, we don't see death or impotence. There are usually a patient is alive, and then we describe certain outcomes. The other problem with our outcome measures is that they influence life and death decision. So if, for example, a child has a brain bleed, we would speak to the parents in the NICU and say, oh, according to what we see, your kid is at whatever 70% risk of having a major neurodevelopmental impairment. And parents hearing that will say, whoa, major handicap, major disability, what should we do? Should we reorient care? Should we stop the respirators? And there's no input for families who are given these outcomes. We don't say this is what happens to families who live with children. We say this is how we categorize these kids in order to take these decisions. So how can we integrate parental perspectives? We can investigate what matters to families, to all families, and patient and parent important outcome, especially with PCORI in the US and SPORE initiatives, are very important. Perhaps there's a researcher important outcome that doesn't matter to a parent, or a parent or a patient outcome that really matters that we forgot about investigating. So the aim is to improve what is most important to patients or families. It doesn't mean we can't measure everything we're measuring, because we need to decrease any bad outcome, but we can also aim to decrease the bad outcomes that matters most to children and their families. It is complex to do these studies because it needs to be representative. So often, unfortunately, there's qualitative studies made with 6 parents, mothers who are willing to speak about what matters to them. And these 6 mothers who are willing to speak in a focus group or in interviews don't necessarily represent all parents. We need to use mixed methods, meaning a blend of qualitative and quantitative methodology. And we'll tell you about our results. And we have to integrate qualitative and quantitative. And that's often a problem because out there's qualitative researchers and quantitative researchers. And it's almost like a religion where both don't speak to each other. And we need to use both. And I like to actually call it placing a p-value on stories. So asking all parents what matters most to you, they tell you a story. We look at what parents speak about the themes, and then we look at how often the parents invoke that theme. So I would avoid only qualitative studies with small n's to decide what is important for families, because that can be extremely biased. It can give us ideas of themes, but it doesn't confirm that it's important to all parents. I also avoid focus groups because it's a biased group of parents that go to focus group that are able to speak about what matters to them in a large group. And that's actually even hard to speak about what's important in taking life and death decisions. Often that's tough to do even with your husband in some cases. So to go in a focus group, it's specific kind of parents and patients who go there. Delphi consensus are also biased because people are so different that it's very hard to reach a consensus. Something else that is to be avoided is a quantitative questionnaires designed with non-parents. So a doctor will write a whole list of what he thinks is important: cerebral palsy, limping, and may actually forget sleeping difficulties, which may be important to parents. So there's a lot of omissions when the questionnaires are made by physicians or only researchers without a lot of parents. Flexibility is also critical. We see a lot of questionnaires that are online that only 30% of people answer, or only on paper, or only with an interviewer, or only on the phone. And what we try to do is to integrate everything. We ask parents, how do you want to tell us about what is important to you? And some would rather have the paper, some would rather speak on the phone, and some would rather speak to a person, have an interview. So also, there's literacy problems we have to think about. So in summary, before I speak to you about the research, measuring outcomes of after preterm birth is important. And for clinicians and researchers, a good outcome, what it means is disease-free, intact survival without neurodevelopmental impairment. But for parents, let's see what they tell us. So this is one of the publications. You can find it in the Journal of Pediatrics. This was the first publication that Magdalena Jaworski did, where we asked 190 parents or very preterm infant at their 18 to 22 month follow-up visit 2 questions. One was, what concerns you the most about your child? And also, not all negative. We wanted to ask, please describe the best things about your child, because most of the literature is negative based as opposed to positive based. There's also good things about that kid, not only what he can't do, but what he can do. So there was 80% follow-up of this cohort. And 80% of parents, participated. So these are examples of what parents, some quotes, she's doing much better than I thought she would. People love him, he lights up the room. Other parents, the concerns, I wonder if he will be like other kids. She's not using many words. I wish she would talk more. So 73% of parents had both positive comments and concerns. And 27% of parents had only positive comments. None of the parents had only negative comments. What was also interesting is that there was minimal associations between what parents said and between the level of disability that we found in children in an objective manner. So for example, a parent of a child with cerebral palsy and a hearing aid would not have less positive comments and more negative comments. So these are the positive themes that are not in the literature. 61% of parents spoke about their child's personality as something that was extremely positive, that they were easygoing, social, curious, affectionate, perseverant. Then 40% spoke about happiness. This was a big theme. He's smiling, he's always in a good mood, he makes people happy, he laughs a lot. 40% spoke about their developmental outcome as being positive. For example, making progress, language, global development. So I'm very proud of his development. He's pretty good, better than what I had expected. Another example of a quote, mom wrote, adorable little boy, happy, determined, working hard, social, and outgoing. So these are positive themes of what parents say about their children. The parental concerns, or the negative themes, many of them are those we measure, but only 56% of parents spoke about developmental concerns. Although they were important, and it's things we measure: language, psychological and behavioral, unfortunately, we don't measure it. Motor and global development, we do measure. So some of the developmental concerns of parents, such as behavioral problems, we don't measure very well, or the psychological problems. 15% of parents said, I have no concerns. But then these in blue and red are what we fail to measure. These are also valid parental concerns. So physical health concerns. My child doesn't feed well, doesn't want to eat, coughs all the time, is readmitted at the hospital, is very fragile, doesn't sleep. A quarter of parents had physical health concerns, and 5% had concerns about the future. So these are examples of quotes of what we actually don't measure in neonatal outcome studies. His behavior worries me. He gets mad. He is aggressive. He only eats purees. He does not eat on his own. He has difficulty to fall asleep. Her lung weakness, she's so fragile with infection. And then in the parents who didn't have any concerns, actually, I'm worried about your opinion, not my daughter. Again, this is just a table from the article that you can go read if you're interested, that parents responded the same way regardless of level of neurodevelopmental impairment. Neurodevelopmental is not the only important outcome. We can see that there was a lot of outcomes that were important to parents. So happiness, good personality, making progress. And there's parental concerns other than neurodevelopmental outcomes that we are not following. So we decided altogether to do a bigger study called the Parent Voice Project. And actually, we're repeating that study with concerns and positive everywhere in Canada. And we're having, our team has several investigations, and I'll only speak to you about one of these investigations. So the Parent Voice Project, there's 2 mothers of preterm infants who participate, follow-up doctors, a sociologist, another follow-up doctor from Saint-Justine, Magdalena, who is the first author of the article I spoke to you about, who's a rehab doctor, and there's been a lot of students and research coordinators working with us. So our goal is to engage parents to co-create definitions of neurodevelopmental impairment. So what we did in our project is during a year, all parents that came for follow-up in Saint-Justine at 18 months, 3 years, 5 years, and 7 years were asked open-ended questions and closed-ended questions. So open-ended questions is a questionnaire, but you don't check boxes. You actually ask them what is important to you, and they give you an answer. We had a very high participation rate, 210 and 250 parents who came. The first question was, please rate your child's health from your point of view on this scale from 0 to 10. This was, of course, not an open-ended question, but just to see how they rated the health of their child. The mean was 8.2. It was very rare for parents to be under 6. A lot of kids, parents judge the quality of health at 10. Then we actually asked parents if you could improve up to 2 things, anything possible in your child's health or development, what would it be? And respiratory health was up there. 25% of parents said she's always being readmitted in the hospital. She needs her puffers. She coughs during the night. Her sleep's not well before she coughs. Examples of what they said. About 25% of parents said, I wouldn't improve anything. Everything's good. And then we confirm what we found in our smaller study, that behavior and mental health was important. Anxiety, being very timid, sometimes aggressive behavior or crisis. Feeding and growth was extremely important. And then the last theme was cognition and learning problems, which were not for parents what was the most important items. We asked parents, please tell us 2 positive impacts of your child's birth that you consider the most important on your life and family. The first question, in fact, was, did prematurity have positive, negative, or both positive and negative impacts? 80% of parents said positive and negative impacts. They spoke about both. And a minority said only positive impacts, and 1% spoke only about negative impacts. So these are the examples of positive impacts of prematurity on their lives, because we never ask about anything positive. So parents speak about the outlook on life. For example, this birth gave me a different perspective. I used to be stressed about a parking ticket, and now I know I'm lucky to be alive. Going back to basics, enjoying life and health, being happy every time you wake up in the morning, knowing that, you have the privilege of health. There's also the parent's outlook of life life is a miracle. We're so happy to be breathing, and that gratitude that we have towards life in general. And the third positive, the major theme, there was a lot of minor themes, is the child's health and development. He's doing so well, she's doing so well, and also the family function. I got closer to my couple. We got closer to a family. We know that family is important now. Our family is stronger. And we see that we've written, this is the post group, is the parent on the other side of treatment. We're a bunch of healthcare providers in neonatology who also had a child who went in the NICU. Some of our children have problems, others died, others are doing well. And we speak about the fact that parents are more vulnerable, but these families are also stronger. And we were surprised to find the same themes brought up by parents, or maybe not surprised, but the same themes were brought up by parents than the themes that were brought by healthcare providers. This is an article in Pediatrics. So gratitude, perspective, relationship, forgiveness of us or healthcare providers, or life in general. Definitions of perfections are changed. It's not 95%. There's other definitions of perfection. It's not what is perfect and fast that is suddenly a good outcome. There's also resilience and other things that we can measure. And this balance of strength and vulnerability, parents describe it to us. You know that you're stronger than you think, and you know that what you can and you can't control, and you're able to then become more vulnerable and stronger when in specific ways that help you. And of course, for doctors, the intolerance of clinical mediocrity once you've been on the other side. Now, what were the negative outcomes related to prematurity, the negative impacts on a family's life? Parental stress and fear. This was very strong. A third of parents said that. There's mothers of twins, even when they were 7 years old, I'm giving an example, went every night, twice during the night to check if they weren't dead. Some post-traumatic stress that is out there that we are forgetting to ask about and to treat. Also, the parents' loss of equilibrium, especially the first year. We saw that a lot the first year because there's a lot of appointments, there's more visits to the emergency room, more rehospitalization. And one rehospitalization is a loss of equilibrium for the siblings, the mom, the dad who may stay in the hospital, or the mom who may stay in the hospital, the parents who may not be able to work. This may be worse than a static problem such as deafness. And some parents actually spoke to us about this, that going to the hospital every month and being hospitalized for a pneumonia is worse than just organizing the hearing aid twice a year. And of course, the stress that goes on with the future of a kid who may have problems. Then we asked the question to improve what we could do as providers, and as parents, knowing what you know now, what do you wish doctors would have told you about premature before or after your child's birth? A third of parents said nothing more, it was perfect. A third said be more optimistic, or even half said be more optimistic. You're always speaking about problems, diseases, conditions, your child may have this, that, but you could also say what kids can do and not only what they can't do. Give us hope, give us positive framing. Instead of saying there's 2% risk of being blind, tell us 98% of kids are not blind. And there's very nice quotes, stop with the doom and gloom and just smile a little bit, written by parents. And I guess this is maybe the way we are as doctors. We want to really prepare parents for anything that can happen and list all the the potential bad outcomes that may happen. But on the other hand, that's not always constructive. As parents tell us, we could also tell them about what is positive outcomes too. A lot of parents spoke about the last theme, which was invoked by a third of parents too. Parents could speak about more than one thing, so that's why it doesn't add up to 100%. Spoke about the outcomes of preterm babies after the NICU discharge. They say, well, you say he may have cerebral palsy, but what does that mean? How are the functions of these babies? How many appointments do they have? How can we be a family? Can we go on vacation? Is it possible, should I buy skates for the others, or we just have to stop skating altogether? So really functional ideas to parents and descriptions, as opposed to just disability descriptions. So our goal is eventually to revise the Canadian Neonatal Follow-Up Network data collection and to report not only what we are reporting, deficits, problems, but also a list of meaningful outcomes that can be collected. So this is the next step, to create a meaningful definition of neurodevelopmental outcomes. So I'll finish with how we can do research with families, because it's what I'm specializing in and what we specialize in our research center. We have to start with humility and curiosity, that we may be the experts of patients' healthcare, but parents and families are the experts of their children and of their families. So for some items that we describe as a disability, parents may not see that in the same way, or they describe often more as the functioning of their child that exists within their family, so the functioning of their families. And we've been wrong about many children in the literature. You could ask for Dr. Sheets, who could tell you about trisomy 21, or we have done a lot of research with, these are examples of pictures of families who live with a child with trisomy 18, or a family who's at the funeral of a child with trisomy 13, of describing children with disability words as opposed to with function and how they are within their families. So how do we do this? We incorporate families in the study design. Parents are collaborators in the research team from the start. What are we looking for and why? Parents can help us to co-construct the questionnaire and the methodology, which open-ended questions, how to do an information sheet for parents. They're actually made much better when parents make them than when it's researchers. Being sensitive to parents too. Some words can seem insensitive to parents without us knowing. Also the IRB, all the informed consent sheets, when we make them, they're about 7 pages. When parents make them, they're a page and a half, and they read much better. And it's actually easier to go to the IRB and to justify why it's a page and a half when 20 parents have made the IRB consent form with you. Involving a parent in the analysis of results, we had 2 parents that were involved here in the analysis, can be interesting. So I'll give you an example. If a parent writes, my kid is running everywhere, she's great and extremely active, a follow-up doctor will say, oh, geez, this is a negative. This child's hyperactive and can't contain himself. And a parent will say, oh no, this child is just bubbly and the mom is telling us about how he keeps the house alive. So these will be important because interpreting stories and narratives of parents, you need more than just one group, a specific group of researcher, because you're only going to find what you want to find. And this is what I've found about qualitative research. It's often read by 2 people specializing in a specific area who kind of recognize the themes as opposed to our group. So we were 10 to analyze the data. Some of us, there was medical students who didn't have kids, parent of a kid who's disabled, one not, a rehab doctor, a neonatologist, and we had to agree on the themes and how to categorize what parents said. Involving families also enriches the manuscript and the publication. For example, Rebecca in all her publications said, why do you always write you 10% death? Why don't you write 90% survival? Why is it always negative terms that are used in the neonatal literature to describe, as I gave as an example, 2% blindness instead of 98% that can see? And it's actually helps us afterwards to, I think that's one of the essential items in research right now, is to inform families and participants of the results of any study we do. So when they consent, we ask them, do you want to receive information about the study? And yes, no, and then we send them a paper or we send them the results, and we sometimes have
Bear with us a second. Looks like Annie's computer's froze.
So the take-home messages: measuring and predicting outcomes is essential. Categorizing children is inevitable. We need to improve our outcomes, get better. Parents need to be informed about outcome research and understand why we measure their children. They should be partners in this research and help optimize research questions and priorities. So thank you for your time. And I don't know if some of you have questions.
So that's my cue to encourage folks to pose their questions in the question and answer box. And we have 3 questions already ready for you. So I will just start. Jeff has asked, oh, it just popped on my screen. Jeff has asked, what percentage of children develop typically after a normal MRI versus those who have an abnormal MRI?
So we're speaking, if we speak about children less than 28 weeks gestational age, then it depends which child gets an MRI. But if you give an MRI on all the kids, then there's many studies. So I'll tell you an average. If the MRI is normal, then again, define normal. It depends how you define it. About 90% develop normally with our definition of what's normal. Then if the MRI is abnormal, 50% have a disability. It's usually cerebral palsy, and 50% are devoid of disability. Then again, the MRI cannot predict a lot of things. It can't predict hyperactivity, learning disability, et cetera, deafness, how social kids are, anxiety. It's associated mostly with cerebral palsy. And there's nothing we can do now with the MRI results. There's no intervention that we can do to optimize outcome with that result. Like the follow-up does the same thing, seeing a physiotherapist, for example.
Jeff has also asked if we could see the take-home messages slide again. Your screen froze for a little bit.
Oh.
And if we could see that again, that'd be great.
Share.
And
Okay.
while you're doing that, I'll look at the other questions. So Jeffrey has asked.
It seems to be frozen. Wait, super technology. I'll try to échappe. It doesn't want to.
Doesn't want to go back?
No, unless I de-share it. But then I'm afraid I'm going to not share myself anymore. Yeah.
Well, okay. If it is not possible,
yes.
Oh, there we go. Here we go. Wonderful. Thank you. Jeffrey.
Okay. Yes.
Jeffrey has asked, have you looked at family outcomes as opposed to child or parental outcomes? And I think you alluded to some of that. A few possible examples. How has the family been impacted by the diagnosis? How has the family adapted following diagnosis? Have there been role changes, for example? How has family support changed? And is the family able to communicate about difficult subjects such as the child's health?
So I'll give you we've got a ton on that. The positive impacts were here. So the parents' outlook on life has changed. When they say they are stronger as a couple, yes, they can communicate about important things. So there's a quote like, my wife and I always used to nag each other about our socks. Now we can have real conversations. Examples like this. So the parents' outlook on life, these are in the positive impacts, because there's negative impacts too. The parents' outlook on life has changed. It got them closer together. Many parents say that it got their family closer together and their dynamics are better in the family. Now, of course, in the negative impacts, I'm going back to my slide, there's parents' loss of equilibrium. This is mainly due to time at the hospital. So we're not looking in our neonatal outcomes, for example, at rehospitalizations. They seem to be terrible for parents. And as you mentioned, one of the parents will stay in the hospital, mom or dad. The other one will take about parents' duties and will lose work, will not go to work. So this is not measured. This is not something that we measure, but it's actually very important to families.
Jamie says, thank you for this very insightful look at parents' concerns. what was the N of your qualitative data collection and the demographics in terms of ethnicity, first pregnancy, age? Would the responses be different given these demographics, or would you consider the responses to be universal across them?
So we had 250 parents of children who were born at less than 28 weeks who visited in a year. 210 participated. So it's a very high response rate. So we feel confident this represents our parents. Most were in a relationship. Now in Quebec, half of babies are born to unmarried parents. So being married is not, unlike other places, something we can look at. We have a fair distribution of what usually we have. We're a big city in Montreal. I think we're representative of potentially Canada. But you see, interestingly, that none of the parents have spoken about money. I mean, we have a year maternity leave. We have universal healthcare system. Parents have an 18-month appointment where they see everybody, a psychologist, they see OT if they need to, PT if they need to, speech if they need. They complain about too much appointments. I'm not sure an underprivileged parent in the US would answer the same thing. I'm sure we would see finances there somewhere. So we have to be proud. We often say bad things about our healthcare system, but I think the fact that finances, not one of 210 parents have spoken about it, is actually a good sign.
Absolutely, it is. Makes you a little bit grateful sometimes, despite all the problems. One anonymous poster says, parenting is difficult in the best of circumstances. Do parents of preterm babies get extra help in parenting, and do they want that help and resources?
Well, yeah, parenting is difficult. I'll go back to the negative and positive. I think one thing parents tell us, those who have other siblings, is, oh, wow, it can be so much worse. So if you actually are afraid for your kid's life for 4 months, then when they wake up, that's what they tell us. It's not as bad. You're just grateful that they're alive. You're grateful for the miracle of life that they tell us. So to some degree, yes, and it speaks to the stronger and more vulnerable. I think parents of preemies, because of what they went through, are stronger, but they're also more vulnerable. So yes, they get scared. Their kids is dying during the night a lot more than other parents. Are we good at helping them parent? I think we are good in certain aspects. So if the child has a limp, we can help them optimize development for that kid. If a child has a problem at school, we have some system, although imperfect, to help them. On the other hand, where we're not helping the optimal way is everything I spoke to you about, negative impact of parental stress and fear. It's not normal to wake up when your child is 6 and not at risk of dying more than another child and go check twice during the night, every night, to see if he's alive. So I think the family function, and this is things that we want to come out of this study, is at follow-up, we have to ask these questions. And these parents need interventions for post-traumatic stress. They need interventions for anxiety. They need, we don't want that anxiety then to actually have an impact on their children.
Thank you. Another anonymous poster says, are you doing brain MRIs for extreme prematurity?
So now that we do brain MRI as part of research, all the families are offered one. And the way I present this to families, myself, is, well, we are doing interventions, we are examining the brain. Eventually, we think this might help. Do you want to be part of this study? I'll tell you what this study is about, and then I'll tell you the results. If we find that the MRI is normal, the majority of children have no disability. If we find that it's abnormal, half the kids have disability. And then I tell them, some parents, it helps them prepare for the future and say, you know, we're going to work super hard. And other parents, it just destroys them and said, you know, I've been here for 4 months. I've been through everything. I don't want to have something else bring me down. Other parents too don't want to have, and we have to remember this, that this MRI result is going to be in the kid's chart all his life. So an abnormal brain MRI, half these kids will have no disability, but even as adults and young adults, they will have in their file the fact that their brain MRI is abnormal. So we have to remember that. And with this kind of counseling, about half the families want the MRI and the other ones don't. And I think we have to be upfront with families when we measure things for research purposes or our interest. It's the same thing with whole genome sequencing. I think it's important to, even though it's exciting new technology, really speak to families about what it means.
Yeah, that's an important point, that it lives on in the chart. Wondering if we have work to do with people who read those charts, not making assumptions or ascribing to that child disability where none exists.
Or insurance companies.
Yes.
Or
yes.
schools, when they ask you, did your child ever have a scan? Yeah. And then, you know, like me, I refused the MRI. And when my kid went to public school, I said she was born at 3 kilos and I had an Apgar 999, because I don't want people thinking, oh no, you know, well, this kid was preterm, and just decrease their expectations and have more pity, and a lot of parents do that now.
Oh, yeah. The advocacy that goes on behind the scenes for our little people. Last question. Given behavior and mental health is identified as integral to the parents, do you have a sense from parents how important it is to convey the increased risk of autism, which can occur with extremely preterm infants? And that's from Deb.
So there were several parents of children with autism, but the autism, the rate is low, and parents have not told us about that. What seems to be a higher rate that is really not well looked at is anxiety and being timid, being alone, not interacting as well with other children. And anxiety was a bit overwhelming to see how many parents mentioned that. And then it's hard to know, is it the hen or the egg? Is it parents' anxiety that's being transferred to their kids? Or is it kids who are anxious because of some developmental item? And this, I think this needs to be assessed. And needs to be measured and to actually try to do something about it. So no, autism didn't come back, although there were 3 parents who have kids with autism, and they spoke about it and it was in their big concerns. But I think there's a lot more psychopathologies that we are not addressing, that kids can function, but even then they have fears, they have difficulty falling asleep, they have other things we're not measuring where we could help.
Thank you so much for taking the time to respond to the questions. And that's the end of our time together today. So I want to thank you, Dr. Janiver, for sharing your time and expertise with us. Thank you to all our members and other attendees for spending this time with us. We hope you depart with some practical wisdom to bring back to your organization. We have a packed fall live webinar schedule. Join us next week on October 28th at 11 a.m. Eastern for Closing the Evidence Gap on Cannabis, Youth, and Chronic Pain. And we're bringing that to you in partnership with Solutions for Kids in Pain, or SKIP. And on November 4th at 11 a.m. Eastern, we're pleased to bring you Imagine, Complex Genomic Testing, Keeping Families at the Core. As well, registration is now open for our annual conference taking place virtually on November 16th to 20th. To register, visit our website, children'shealthcarecanada.ca. It's always great if you can watch live as your questions and comments enrich the discussion. But if you can't, the recordings of these sessions are made available after the fact on our Knowledge Exchange network. So thanks again for joining us today. Thank you to Dr. Janvier for this presentation, Children's Healthcare Canada member Saint-Justin, and Mallinckrodt for supporting our webinar program. And hopefully we'll see many of you back here next week. Bye, everyone.